Hi, everyone. I'm a medical oncologist. I feel very honored to be in this meeting. This is my first time in the meeting. I really want to thank everybody for inviting me. I also wanted to thank the previous speakers, Dr. Alba, Dr. Hamstra, and I wanted to echo what Dr. Hamstra said about the multimodality therapy. We have one of the Hoosier trials. It's multimodality. We give immunotherapy, and then based on the CR or how they have responded, they go to adaptive approach. And I can tell you that the biggest challenge is coordination between the three specialties. So we feel that having our nurse navigator has helped a lot, but it's still a challenge when we are going through these multimodality therapies. So, okay, so I'm gonna talk about advanced bladder cancer, and my attention span is very short, especially if it's about something that is not something I see every day. So I try to keep this presentation as short and brief as possible because I know you don't take care of metastatic patients. All right, these are my disclosures not relevant to the talk today. So this is just a schema of how we are treating bladder cancer in the year of 2024 in different disease states. And we already talked about the first few. And I'm going to focus on advanced metastatic and when they have progressed. And we'll keep going back to these treatment approaches that I've highlighted here. So things changed dramatically for us last year. ESMO, European Society of Medical Oncology, which just ended 3 days ago on Tuesday. Last year, ESMO was a practice-changing meeting for bladder cancer. And really, the treatment of metastatic bladder cancer, we can divide it into pre-ESMO 2023 and post-ESMO 2023. So pre-ESMO on the left, we use platinum-based chemotherapy followed by durvalumab, avelumab maintenance therapy. Or if patients were cis-ineligible, we would use pembro plus enfortumab. But then after the ESMO presentations, things changed. And we'll go over these new standards of care that are listed here. So this is the first study that is the most important study. This is a study of EV302 and enfortumab vedotin, which is an antibody-drug conjugate, plus pembrolizumab versus platinum-based chemotherapy. And this is in all comers, no matter if they were cis-eligible or ineligible. This was frontline therapy. And this study was amended while the study was going on because Javelin Bladder 100 got maintenance avelumab approved. And because of that, patients who were on the control arm of chemotherapy also were able to get maintenance immunotherapy. So about 30% of the patients on the control arm got adjuvant maintenance avelumab. But as you see here, these curves separate beautifully. Just within around 2-3 months, they start to separate and they continue to separate, and that's the overall survival curve of these patients. And the numbers are just impressive for a patient with metastatic bladder cancer. As you see, it doubled the overall survival of these patients. And it reached a median overall survival of 31 months, which is something that it was unheard of before for a patient with metastatic bladder cancer. And this was compared to 16 months for chemotherapy. So this trial got a lot of standing ovation at ESMO last year. And I was just talking with George, one of our colleagues from industry, and he was there. And he said that they kept interrupting Dr. Powell's and clapping at the PFS curves, and then clapping at the OS curve. And Dr. Powell, I was listening to an interview with him, and he said, I knew this was nice data, but after I was done and people stood up and kept clapping for minutes after minutes, I was like, oh, this is good. So it is really, we are very excited about this. And then the next study that was presented at ESMO last year again was the Checkmate 901. Again, a positive study, nice data, but because of the EV302, I think this went under the shadow of EV302, this study looked at nivolumab plus gemcitabine cisplatin versus gemcitabine cisplatin alone, which was the standard of care, in frontline metastatic bladder cancer. And this study also, on the control arm, around, I think, 15 to 20% of the patients ended up getting maintenance avelumab immunotherapy. And as you see, this study also met its primary endpoint. It met its PFS and OS endpoints, and the curves separate. The numbers are still nice, not as impressive as EV plus Pembro, but still a positive study, which is now one of the frontline treatment options for our patients with advanced bladder cancer. So a little bit of comparison between the response rates and some comparisons. And I know we always keep saying that we don't want to do cross-trial comparisons, but when we want to decide which treatment we want to give to our patients, we do that because we want to give them numbers. So these are the response rates. On the left, you can see EV Pembro, and the response rates were really almost 68% response. And I want to highlight the dark navy, the lower one, that's 29% complete responses. Again, we start thinking, can we cure some percentage of these metastatic bladder cancers? And on the right, you can see the Checkmate 901, Nivo Gem-Cis. The overall response rate's 57%. And there is a dark blue or dark turquoise up there, 21% complete responses. Now, what was presented at ASCO, the parent ASCO in June this year, was some subgroup analysis from Checkmate 901, the study with Gem-Cis nivolumab. And they looked at patients who had lymph node-only metastatic disease, which again, we just were talking about lymph node metastasis and what we should do for these patients. So when they looked at those patients, on the left, you can see the overall all-comers responses. And then the right, they saw patients who had lymph node-only metastasis. They really had much, much higher overall response rates and complete responses with this combination of chemo and immunotherapy. Response rate as high as over 80%. And then they had complete responses, which were amazingly high at 60%. They looked at where these lymph nodes were, and it didn't matter, regardless of the site of the lymph node. These patients who had lymph node-only disease, they had better responses, especially if they had pelvic lymph nodes or retroperitoneal lymph nodes, the two on the left. So how does this impact our practice? I don't think we know yet. On the left, you can see EV Pembro results on lymph node-only metastasis. And as you see, there was a 77% response. I don't have the complete responses on these patients. And and you see their overall survival curve, which again, it separates nicely. And on the right, you see the Checkmate 901 Nivo Gem-Cis in lymph node-only metastatic disease. A little bit of a better response, 81% of response, and nice complete responses, and nice separation of the curve. So the question is, how does this change the practice for our patients who have lymph node-only metastasis? So I think these are my takeaways from these two practice-changing trials in advanced metastatic bladder cancer. EV Pembro is the current preferred standard of care by both NCCN and ESMO, given the impressive results in overall survival and responses. EV Pembro is not a walk in the park, though. I mean, it's not chemotherapy, but the ADCs plus immunotherapies, they can be pretty toxic. So we are learning, just like how we learn to manage toxicities from immunotherapy, we are learning how to manage these toxicities, how to maybe dose reduce or dose interrupt to be able to keep our patients on these treatments. But the thing about it is, currently what is approved is indefinite treatment with EV. And you stop Pembro at 2 years, like a lot of other immunotherapy studies. But then the EV technically is going on, and I can tell you that I don't think any patient can tolerate EV indefinitely. I think that there are many other studies, especially smaller center studies, that are looking at different, dose schedules and not giving it constantly to the patients and giving it breaks to the patients who are having nice responses. But I think that we have to learn how to manage these doses to be able to keep the patients on it and help them get the benefit from it. What about nivo-gemcis? So nivo-gemcitabine cisplatin, it's a possible standard of care for first line if our patients cannot get EV pembro for any reason, or if our patients don't have access. I mean, here in US, our patients have access to it, but in a lot of other places in the world, it takes a long time before these new standard of cares are really incorporated in the practice. And I think possibly, especially if the patients have lymph node-only metastatic disease, it could be maybe we should discuss and figure out if that's going to be a standard care. If we want to try to do a consolidative cystectomy, is this going to be something that you'll be interested in? And I'm really curious to see what you surgeons think about this. If you want to do surgical consolidation or radiation on these patients. I think it's more patient-friendly. You get 4 to 6 cycles of chemotherapy, and then you get 2 years of nivolumab, so it's not indefinitely. And I think the toxicity is a little, at least we know how to manage the toxicity. So I don't want to say it's better toxicity profile. I would say we know how to control it better. But I think another question also is, what is the standard imaging? If we want to decide if we want to give this treatment to the patients and do eventually a consolidative surgery, I wonder if it should be a CT, MRI, what kind of universal imaging do we agree on to put patients into that route? So here is the choice of treatment we have now for metastatic bladder cancer. I'm not sure if we really should look at cis eligibility anymore at this point, because enfortumab vedotin and pembrolizumab is approved for all comers, regardless of cis eligibility. But I think we still could, because gem-cis nivolumab is an option if our patients are cis eligible. The question is, what should we do after these patients have progression? There are several options at this point. Erdafitinib for patients who have FGFR 2 or 3 alterations. T-DXd, it's a HER2 positive, in HER2-positive patients, and we have a slide, I'll show you a slide on this. Platinum in the second line, we could use it. And sacituzumab govitecan, which I put a question mark, and I'll talk about it, why I did that. But I think that the question is that all these on the right were approved in patients based on patients who are progressing after chemotherapy, after immunotherapy. So we don't know how relevant they'll be if it is after EV plus pembro. So we have to look at different sequences now. This is one slide on the HER2 targeted therapy that I just talked about. This is Destiny Pan-Tumor-02. And it looked at the HER2-directed antibody-drug conjugate, T-DXd. And it was in all different solid tumors, patients who did not have any other approved options. As you see, endometrial, cervical, ovarian, bladder, biliary tract, and pancreatic, and others. And I put a red box around bladder because that's what we're talking about. There were 41 patients with bladder cancer on this trial. And the ones who were HER2 3+, they had a very nice overall response rate of 56%. And the ones who were 2+ had a 35% response rate. And based on this study, FDA, April of this year, gave accelerated approval to T-DXd for patients who have unresectable or metastatic HER2 positive, IHC 3+ solid tumors. And because of that, NCCN also has now incorporated it in the subsequent therapies for patients with metastatic bladder cancer who are 3+ HER2 positive. So that's another option that we have. There are so many still unanswered questions. One is, what is the optimal therapy for patients with lymph node-only metastatic urothelial carcinoma? We also already talked about what is the optimal therapy for patients who have already gotten treated with this impressive first-line treatment and have progression, EV pembro. I think another question is, where does HER2-directed therapy fit, and how we really want to use this in practice? Because a lot of times these patients don't have a fresh biopsy. It's an older biopsy. Are we going to re-biopsy them? Or are we going to use, the initial cystectomy or any biopsy they had? I can tell you it's not easy to re-biopsy patients. They don't like it. Sometimes we don't have any good lesions to biopsy. There were also some preliminary results and some results on HER2-directed therapies with DB, which it was just a safety run-in, and it was on 20 patients, but it had a 70% response rate. So I think the HER2-directed therapies also will start moving forward. I think, and the last question I put is, what is the role of sacituzumab govitecan, again, another antibody-drug conjugate, in the refractory setting? The reason I put that down is this is among the options for subsequent therapy. This got treatment based on the TROPHY trial, a phase 2 trial, where sacituzumab govitecan was compared to chemotherapy. It got accelerated approval because it showed around, I think it was 27 or 29% response rate and did better than chemotherapy. So it got accelerated FDA approval after patients had received a PD-1 in checkpoint inhibitor and chemotherapy. But there was a press release on TROPiCS-04, which was the same treatment at a phase 3 confirmatory study. And we don't have the results yet, but the press release a few months ago said that the trial was negative. So what's going to happen to sacituzumab in this setting? And I wonder what would happen to the other ADCs that use a TROP2 inhibitor as their payload. So again, future directions, I put a few of the trials that we are following right now. The ECOG trial that's looking at different combinations, again, with sacituzumab and immunotherapy. The SWOG 1937 trial, which we have open at UNM, it is looking at eribulin plus gemcitabine. Again, another new combination, eribulin plus gemcitabine in the second-line setting, had a 50% response in patients with bladder cancer. The NILE study is looking at, again, different arms of combination of immunotherapy plus chemo. And DB001 is looking at HER2-directed antibody-drug conjugates. So we're looking at sequences, we're looking at new combinations. I think this is a good problem to have to decide what's the best for the patients, because it tells us that we have options for our patients. And the field is really moving quickly. So when I was making these slides, I knew ESMO was going to happen. I submitted the slides 2 weeks ago, and ESMO was happening just this past weekend. And I was like, I know I have to update my slides, but I'll just talk about them. And muscle invasive, I mean, the Niagara study is out now. It was on the presidential of ESMO, and now we're gonna do chemoimmunotherapy for muscle invasive. So new things are coming for bladder cancer, and we're excited. Thank you.